Okay, we are now recording, so please once again take care that you are not unmuting and unnecessary voices are not coming. More people can benefit from this recording later. It will be available for others to watch. So once again, a very warm welcome to this master class.
എന്റെ ക്ലാസ് വന്നതിന് ശേഷം ഞങ്ങളുടെ നമ്മുടെ ഗ്രൂപ്പിൽ ഷെയർ ചെയ്താണ് റെക്കോർഡ് ചെയ്യുന്നുണ്ടല്ലോ ചേച്ചി ഞാൻ റെക്കോർഡ് ചെയ്താണ്
Please mute yourself. You have come here to a class, so please be little disciplined. If I see the same person coming again and again unmuted, I will have no choice except to remove that person. So please take care of that. Okay. So the master class. Anil's iPhone, please mute yourself. I'm sure that you have come here and spending your time to learn something and allow others also to learn. Please. So once again, warm welcome to the class and seriously, I'm going to remove somebody. It is really very disturbing. Anil's iPhone, whoever is holding that, please mute yourself. So Ishita is waiting to come into the class. So thanks especially to Ishita for holding this class together. And really, when you unmute yourself, it really disturbs the mind. If I am disturbed, and she's also disturbed. Ishita, I'm so sorry, I did not remove a R from your name. Her name is Ishita Chandra.
It's okay, no worry.
So please, I'm really sorry. I just saw that, it is written Ishita Chandra. Ishita Chanda. Ishita Chanda.
Yeah.
Okay. So I will say now thank you to all of you, and my big thanks to all of you for staying muted. Please, for my humble request, let's have a very good class. And if you stay muted, yes, it will benefit everyone. And throughout the class, in case you have questions, please put it in the chat. I will be looking at the chat and we will see when we can take those questions and answers. Okay. And we will tell you what more needs to be done to get the certificate. And you know that if you come to Signia and if you come to Thankam, no certificates are going to be given just like that free. There, we will ensure that you learn something before you get your certificate so that you can go back and give it to your organization and to your patients. Okay. So Ishita, there you go. I'm stopping the sharing and you can now share and you can come on the video. So I'm going to put on the speaker view and yes, I'm going to stop my video, Ishita. Go ahead.
Thank you, ma'am. Thank you, and good afternoon to all of you. Thank you, ma'am, for giving this opportunity to share my experiential learning with all of you. Very nice to see so many people participating. I'm really overwhelmed to see the number of people participating. So, some are known faces of mine, some who were trained by me. As ma'am said, I was trained by ma'am in 2013 and 14. I was a ward manager, and it was ma'am who coached me and mentored me. And I think what I am right now is many teachers like that who have been the backbone. And I think same goes with all of you also. So once again, welcome to all of you and happy Teachers Day to all of you, because each one of you are teachers. Okay, may not be as a title as a teacher, but you teaches your life reflects, and many people sees you or watches you and they learn from you. So isn't it a great learning? Okay, so cheer up all of you, and I'll be sharing my screen. Okay.
Oh, 1 second.
Yeah, ma'am, you need to just make the co-host.
Yeah, just let me just, I didn't click that.
Sure.
There you go. Yep. Now you can.
Yes. I hope My screen is visible to all of you. You can just use the reaction emoticon to show that yes, it is visible to you all. Okay. So before we start this topic, pain management is not a topic which is not familiar to nursing. I believe all of you have come across some or the other type of pain, right? In your personal life, in your professional life, and day by day, we see a lot of patients coming to us because of pain, isn't it? So, taking this topic, a quick question to all of you. Since it's a virtual, I may not be able to physically get connected, but I'm sure through this conference call, through this video, we will be able to connect with each other. So, how many of you think that pain management in nursing is painful? Just you can write down in your chat box. Yes, Y for yes, and N for no. How many of you think that pain management in nursing is painful for nurses? Okay. Okay. Pretty many of you have written yes, 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 it's coming. Yes. Fine. All of us now agree that it is a little bit difficult. It is a challenge for us to manage the pain, right? And in India, it is quite more challenging than Western countries, that we have a lot of myths and misconception regarding pain management and pain. So we will be dealing with many things in our coming slides, and I hope that this time, this hour of session will be fruitful to you all as well as to us, because it's going to be a learning experience for all of us, right? So before we start, this is one of my heart-touching quote, I would say. Florence Nightingale, our pioneer in nursing, and we can never forget her, because what we are and what this, and year 2020 is a year for the nurses, by recognized by WHO. So even in her quote, Florence Nightingale has stated that she has found pain in every part of her life. We sitting here cannot deny that I have or you have never ever experienced pain. We have experienced pain, whether it's physical, emotional, or in any way. Loss of a lovable one is painful. Loss of a job is painful. Physical pain because of some disease is very painful, right? So there is a saying which goes, without pain there is no gain, right? So yes, if you and me have never experienced the pain, how are we going to help our patients to resolve their pain, right? So I think all of you have taken the pre-test, and around 89 people have participated in the test. As ma'am was telling, we actually anticipated that, we'll get a pre-test score will be pretty high, 90%, or, above 80%. But to our surprise, it is around 60%. But there where it shows that we still need to learn more about pain management in nursing. So we'll be having tests also in our coming time after the session also. So you need to be very carefully listening, not hearing. I want all of you to listen carefully as we proceed towards our topic. Now, all of us will have an objective. There are some 67 participants, 65 people who have come here across. I'm sure you must have thought something in your mind when you have come here. I know that though your nursing heads have nominated your name, but back in the mind, you must have thought at least, okay, let's do this training topic on pain management. Must have something in your minds, right? So even same thing, I also have some objectives for this class, which I thought will be helpful to you all. So these are pretty self-explanatory, and I'm not going to go into details of the objectives. As we come across the topic, you yourself will be able to understand better. So if we talk about pain, okay, So there is again a chat box. So see, the chat box is going to be help. It's like a communication for between you and me. So I would like to know, write one word that comes into your mind when you think about the word pain. Just write down what is the word that comes in your mind when you think about pain. Discomfort, unavoidable, hurting, very good, unpleasant, pretty, yes. Well, thanks a lot to all of you. Yeah, good. So any of these words, are these words a very positive words or a negative words? Looks like little negative word. Okay, none of us would like to experience pain. Now, right now, we are total 66 people in this group. And if any one of you are having any discomfort related to your environment factor or with where you're seated here, some noise, some distraction, or you yourself having some pain in your body, will you be able to sit comfortably and listen carefully? I don't think so. You'll be able to do it, right? So pain is such an important, crucial point where it changes our body pattern, it changes our lifestyle, it changes our personality, right? So pain is not a very pleasant thing, as correctly many of you have said. Okay, so pain is quite a very difficult situation. So pain happens all across the age, from the newborn till the old age people, geriatric group, you will see pain. Pain is basically a very uncomfortable feeling. None of these faces that you see here are happy faces, right? It's a pretty uncomfortable feeling, a discomfort. Now, if my chair is having a pin or something, I will keep on moving here and there. Why? Because this is giving me a discomfort. I'm not comfortable. Unpleasant feeling. Now, sometimes pain doesn't come as ache. It comes in the form symptoms like many things. When you're emotionally stressed, when you're hurt, you try to aloof yourself from others, right? That's a pain in your heart that you are undergoing, you're facing it. It's an unpleasant feeling. So, pain, it is a very, the statement is very clear. The last one says that pain is whatever the experiencing person says it does. Now, I would like to phrase it again that pain is whatever the experiencing person says it does. It is only what the experience in the person or the child or the wife or the geriatric patient, the person who is undergoing or experiencing can only tell what he or she is feeling. This is why we say pain is subjective. It is subjective. It is my own perception. You cannot say, hey, oh, you got a small cut and you're crying so much. Yes, I'm crying so much because it is hurting me. It is my pain. I am experiencing it. You cannot make a general statement that with this cut, I don't think, any people will have crying or anybody will be crying as much you're crying because it is my experience, right? So that's why pain is a subjective. Now, before we go into the types of pain, and these are nothing that is new to you all, would like to look into a little bit about the pathophysiology. I'm not going to the theory part of it. Pain, so we have some neuroreceptors. We have a lot of receptors in our body, okay? It's in the superficial part of the skin, it is in the viscera, it's a deep organ. Everywhere we have receptors. Pain receptors, these are called as the nociceptive receptors. The nociceptive receptors, what happens whenever they senses a stimuli, get a stimuli of pain, they travel it through a pathway and goes into a gray matter, and there their gate opens. So there are theories, there are ascending and descending pathway, gateway theories. These are all actually the theory part. We are not going to go into much into the theory part of it, but yes, the cells are present. That's the reason why we get the experience of pain when you get a burn or when you go near to the fire, when you get a pin pricked, we say ouch. It's hurting. Why? Because of the nociceptive receptor cells which is situated all across our body. So coming to the types of pain, basically we all know the pain is classified into two things. One is acute, another one is the chronic pain. Now acute, the word itself says, which comes, the onset is sudden. It comes suddenly, and even stays for over a period of time and it goes by. So, for example, any acute pain is like any trauma, any injury, any cut, any burn, any surgery, anything which has happened all of a sudden is an acute. So, most of the time, now, as I discuss about it, many of you who are working in emergency department will be able to agree with me that most of the patients that you come across are patients who come with pain, whether it's a chest pain, or a leg pain, or a cut, or a bruise, anything is all associated with the pain. And that's the majority of our population of a patient who get admitted because of some discomfort which is associated with the pain. So, symptoms, there are some symptoms of acute pain. So, what are these symptoms? When a patient is suddenly experiencing a type of pain, will have your vital parameters get changed. Your heart rate increases, your blood pressure increases, your respiratory rate also increases. So, you will see when you're having pain, you start breathing, you start perspiration, you start sweating. Have you seen a patient, typical patient of MI, and comes heaviness of the heart, chest pain, sweating profusely? So any patient with a multi-trauma, a road traffic accident patient, will he or she come happily? He'll be howling, crying. And when you check the vital parameter, you see they're all deranged. So acute pain manifests like this with altered parameters of your vital signs. Coming to chronic pain. Now, it is a misconception that when a patient is or any person is having pain for, when it crosses more than 6 months, it becomes chronic. No. Over the period, there are few acute pain which comes to chronic pain, but not all time that your chronic pains are all which is failure to acute pain. The chronic pains are because of some degenerative process, a progressive disease which is spreading all across the body. Slowly, your nerves are getting damaged over the period. Now, the manifestations of chronic pain patient is very different than of an acute pain when a patient manifests. Now, in chronic pain, you may not see that, your fluctuation of your vital parameters are seen so distinctively. Because in a chronic pain, suppose I'm having a pain of my knee arthritis and I'm over 1 year, I know I have got some type of, I have got accustomed to this pain. So I know how to manage it a little bit, right? So my parameters may not be as deranged as comparatively to the acute pain. So in this, what happens in chronic pain, the symptoms that we see is a person who is with chronic pain will have a seclusion life. He or she will not like to interact with people. They'll look aloof. Sometimes they go into depression. If you visit some of their relatives' house and you see some old people, you ask them, how are you, granny or grandpa? They'll say, that my pain is still there and all. But because that's how that pain have been nagging and has affected their personality. Over the chronic pain, you see the patients are getting little bit, their lifestyle have changed. A person who was very active, climbing, are now confined to bed or a wheelchair or a chair. So their lifestyle have changed. Sleep deprivation is one of the very classic thing. You'll ask in patient, many patients say, wo dard ke karan hum so nahi paye. What that means is because of the pain, I couldn't sleep. I have sleepless nights because of my pain. This pain doesn't go. So these are some of the manifestations when you see when it comes to chronic pain, right? So now chronic pain can be further divided into many types of pain. The one of the pain is nociceptive pain. Now what is a nociceptive pain? This is a pain which is actually caused because of the physical damage, because of the nociceptor cells being getting triggered. So this could be any bruises, mark, which is taking lot of time. Typical example, I'll tell you, soft tissue injury. Now, I had an accident some 3 years back, and I had a soft tissue injury where my fracture got healed actually, but my soft tissue pain aggravated for more than 8 months. It was still there for 8 months. So some tissues, some pain are like that, which goes long period of time. So nociceptors are those which are actually caused by because of physical damage to the nociceptor cells. Further, we have neuropathic. The word neuropathic itself explains what is it? Neuropathy. Okay? Pathy is disease, neuro is nerve. Your nerve related any injury. So when I talk about nervous system, definitely it comes two things, CNS and the PNS, the central nervous system and the peripheral nervous system, right? So any damage to a central nervous system and any pain that occurs because of that is a neuropathic pain. Peripheral nervous system. Typical example is your diabetic neuropathy. A patient's prolonged diabetic patients will have degeneration of your peripheral nerves. So what happens is lose the sensation of it. Okay, they have pain. So these are some of the peripheral neuropathic type of pain. What happens in your post herpes herpetic neuralgia? So after the healing of the herpes, the cells, the neurotransmitter or the nerve cells in that particular area gets damaged, because of which they have pain symptoms coming up in that. Okay. Next, we have some mixed type of pain. Now, what is a mixed type of pain? This is typically a combination of nociceptive and a neuropathic pain. So it's both combination of both types of pain. It can be injury pain or a visceral pain, any damage to it. For example, a low back ache, a cancer pain, fibromyalgia. These are some of the mixed type of pain. And the last one is visceral type of pain, which is a deep internal organ pain. Okay, so typically when it happens something outside your body on your skin, it is very easy to locate and say, okay, here I'm having pain. I can see it. But sometimes when it happens inside your body, you cannot peep inside your body and see, right? So some of the internal organ pains that comes out, these are the visceral type of pain. There are some types of pain which is also called as referred pain. Referred pains. So these are pain, basically, this is not at the site of origin, but the pain comes out from other site of, so you cannot exactly locate referred type of pain, not from the origin, but somewhere in the surrounding or from the other part. So you typically see patients or injured liver, spleen. Okay, these type of patients will have a backache, pain, a back pain. They will be manifesting with such type of pain. So this is a brief classification of the various type of pain. Now, why we need to know this type of pain is because we need to know the organs which are associated with it. We can also try and help to minimize and reduce the pain, okay, of the patient, as well as it will give us that what actually we need to do. My interventions should be focusing on the different types of pain. Hope I'm clear till now. Any doubts, you can just stop me and ask me at this moment. But I hope all of you are okay with my pacing of my speech. If you're okay, just put a thumbs up and say you're okay. Till now, you're able to understand what I was sharing. Just a thumbs up will be enough to tell that you're okay. You're able to identify, you're understanding it.
1 second, Ishita, that requesting everyone to please keep your phone muted. Please. Thank you. Yes, Ishita, please carry on. Thank you.
Okay, ma'am. Thank you. So I hope you are able to follow till here. So we have just looked into the definition of pain and the types of pain. Moving forward, we will see what are the causes of pain. Okay. So I'll tell you a story. Okay, now listen carefully to the story. So this was, I think, in the year 2005 or 6 when I was working in a mission hospital, a 100-bedded mission hospital, not like your corporate hospital, in a mission hospital somewhere. And there we had only one surgeon, one medical doctor, one physician, and only that was usually in mission hospital. It is more of nurse oriented. The nurses are the whole, they are the one who takes even decisions sometimes on behalf of the doctors, I've seen. So one of the patient, the surgeon, our medical superintendent was a surgeon. He was a general surgeon. He did he did a lab chole, and he went. And in the night, he did it around I think afternoon or evening time. And in the evening, around 7 o'clock onwards,
नहीं नहीं क्लास
can
है
you mute yourself, Usha Rani? Yeah. So what happened? So we had a medical officer who was on call. So those days we used to have in government also. They have a on call note register where so they used to write such and such patient is having this. So my nurse sent me. I was a nursing head over there. The nurse sent that patient post op with this thing, such thing, complaining of pain. So the phone the doctor said, "How usko painkiller de do." What is prescribed? They gave painkiller. After an hour, again there was a pain. Again they said, "Arey pain, sir, usko pain ho raha, bahut ho raha hai." So it went on for 3-4 hours. Okay, and the patient was crying, howling with pain, pain, pain. So finally, the call went to the medical superintendent because he was a surgeon. He said, "Let me go and see. Is it because of the surgery related or something?" So he comes to the ward, and now what happens? He takes the sheets out and sees, he tries to check in the lap chole side whether is it any pain, any oozing or anything comes. He sees there interesting thing happens. So what happened? He sees in the suprapubic region there is a bulging. Okay, so what is it? Can anyone tell me what is that swelling is? Anybody, you can unmute yourself and say, what is the swelling in your lower abdomen or in the suprapubic region? What is that? What is that swelling?
Retention of urine.
Yes, very good. Very good. Retention of urine. And there, what do you think the medical superintendent would have been doing? He would be presenting a garland to me? Never. He was furious. He was furious and said, "Ki, kya aapke nurses ne ye nahi dekha?" So my girl kept on asking, "Dard hai?" "Haan, dard hai." "Haan." Likh diya. But she failed to see the site. What was the cause of that pain? It was not the surgery pain at all. It was bladder big distended. So once there was catheterized, patient was relieved, there was no pain. So to know or to do some interventions of pain, you need to know the cause of the pain. What is the cause of the pain? What is provoking the pain, right? So there are different causes of pain. We'll look into some of the acute causes of pain. So any damage, any injury, head injury or any blunt injury, anything, any injury which is direct on the body, that is one of the cause of pain. Surgery. The patient post-operatively, we know there will be pain, post-operative pain will be there. So post-operative patient will experience pain. So the surgery the patient is having pain, any fracture. So I was just telling, I'll share one of the experience. It was in 2016. 2017, where my family, we were going on a highway. My son was just 3-year-old at that time. And we met with a massive surgery, like massive accident on the highway on the way to Ahmedabad. Our car toppled down and very bad. So when we were brought to the hospital, I was working with Fortis at the time. When I came to the hospital, oh, soon after this, we were rescued by the team and the public came and helped. I could see that I'm not able to bear my weight on my little toe on my right leg, right foot. Everyone, I said maybe because of some glass pieces has gone, something like that. And there was a deep cut. I never anticipated that, it may be because the glasses would have gone. So when I was taken to the hospital and they said, we'll do, it's an accident case, so we have to do an x-ray. So did an x-ray. I was happy that it is only the cut, that is a deep cut. To my surprise, it was a fracture of my small toe. So it could be a small, minute cut, but it has led to a fracture of it. So that was an acute pain, and you will not believe I was not able to bear my weight at all because of so much severe pain it was. Are immediate causes of pain. All of us, women especially, I know men also are going to the kitchen these days, so must have experienced small type of kitchen burns or some scalds and some, boils. So pain, it's pretty painful. A small, especially the pain with the steam is, the burns with steam is more painful. So these are acute cases. Any fall and any injury. I have a lot of experiences with fall, fractures, and all, and those who work with me, they know pretty that I had multiple of accidents actually. I had again an accident in my own hospital. It was newly operation going to be commissioned, and my FD said we all the employees should park their cars and bikes in the parking area. So we all did. Unfortunately, there was a big pipe. Everybody was having some other problem to climb over there. I tried to be a brave woman, but unfortunately I skidded. I fell. I had a ligament tear, and again I was into severe pain. So any fall, we often come across with patients who have fall in the bathroom, fallen from the bed. The fall is also one of the cause of the pain. And any trauma, any road traffic accident, or any recent injury. These are the pretty examples of causes of pain in acute symptoms. We come to more on some of the causes of pain which are chronic pain. Now, these are typically patients who have pain more because of their disease, some of the underlying diseases, like arthritis. Typical in Indian situation, I think women often have more of this rheumatoid arthritis, osteoarthritis, because of the degeneration, because of the calcium deficit, or a lot of inflammatory disease. So these are some inflammatory causes which causes a lot of pain among the person. Okay, inflammatory bowel syndrome, IBS we say. These are typically patients, those who with IBS will have on and off some or the other type. The moment their food pattern gets changed, moment there's some dietary pattern, anything changes, they have stomach upsets. Patients with peptic ulcers, gastric ulcers, all these patients have severe type of pain and could be experienced in any type of it. So some of these are your neuro-related, like diabetic neuropathy, as we have discussed about it, because of the synapses, your nerve fiber damages because of the progression of the diseases, so they'll have experience of pain. And last but not the least, which is quite challenging for us, is our oncology pain. Okay, so over the period, a lot of research, a lot of studies have been done, but reducing or getting relief of pain for an oncology patient is quite difficult. And I have personally experienced it. I have been an oncology nurse, and I have been seeing from all age, from child. I remember one of the child that was from Nepal, Bhutan. He was just 4 months old, diagnosed with cancer. Okay, from that age group till 80s, 90s, there are people who are experiencing pain, and some type of this pain is very, very annoying. And we would not want our lovable ones to see them into pain. Their pain progresses as they go into metastasis, as the cancer cell, it's very progressive, it goes very fast. I recently lost my father, and I have seen this, how much he was in pain. He used to complain of pain. We never thought that he was actually having cancer. But it is very difficult to see pain when, especially in oncology. And I have been an oncology nurse and experiencing this and seeing with your own father, being affected with this pain is quite very distressing. So now we come across the characteristic of pain. I hope the types of pain and the causes of pain are clear to all of you. Now, looking into this picture, you must be thinking that one corner there's tears in the picture, and the other side a nurse with a smiling face. How does this have a connection? A nurse can wipe the tears if she knows how to handle or identify or tackle the patient's pain. You will be a great nurse. We will be a great person if we are able to reduce the pain, or we are able to help the person to come out of the pain, right? For this, we need to know a mnemonics. Does anyone knows what is a mnemonics to identify the characteristic of pain? You can unmute yourself. You can unmute yourself and say, what is the characteristic of pain? Any mnemonics?
PQRST.
Okay, very good. PQRST. But quite surprisingly, we all know what is PQRST, but unfortunately, the answers we have got for P is quite distressful for us to take it out. Okay, we know that it is PQRST, but we'll know. So let's see what our PQRST is. One of the mnemonics that we use to identify or the characteristic, explain basically briefly on the characteristic of pain. So P is provoking or precipitating or alleviating factor. Any P is actually provoking. What is provoking you, or what is the precipitating factor? Why is this person having pain? So remember, a good nurse will always have few questions. W, why, when, where, what? These questions, these critical thinking should be haunting you. Why is my patient having pain? What is that is aggravating the pain? So P is your precipitating. Q is the quality of pain. What is the quality of pain? We will be discussing this in details. Okay. R, what is the region of it? And is it radiating? So R can stand for region as well as for radiation, both. Okay. S is severity. Now, in one of the literature that I was, referring for this class, S also stands for symptoms associated with it. What are the severity? Yes, we will know how severe is the pain, but also we should know what are the associated symptoms that a patient is manifesting when a patient is undergoing or experiencing a pain. And last but not the least is your time. You should be knowing when is what is the onset of the pain. So let's take it up one by one, and in detail we'll be discussing about it. So provoking factor. Now, what is increasing it? So I'm sure all of you, majority of you are from your NABH hospital and JCI. So I'm sure you have to do a pain assessment, right? Or you have your time of nursing admission assessment. So when in the time when you're doing a nursing assessment, one of the important questions is pain. Even in OPD, you have a screening chart where you ask, do you have pain? In emergency department, even you have to ask about pain. Does the patient have pain? If yes, so what is that which is increasing the pain? We should be knowing what are the factors that causes the pain to increase. So what could be the factors? Some of the factors could be just like position. Position could be one of the things. Certain movements can be painful. Certain activities are painful. Stress, anger, Yes, they also provoke. Your vital parameters keep, juggling with you. Stress. When you're in stress, don't you have headache? Many of you have headache. You say that I'm in a very bad mood, I'm having headache. Yes, it's a type of pain, right? So we as a nurse, we should be knowing the underlying cause of what is the pain, provoking the pain. So I'll tell you a story. When I was I told you I have a lot of story, and I am a storyteller basically. Okay, so uh, it was in my around 8.5 months of my pregnancy. I had a big tummy, and I developed sacroiliitis. One of the thing where I cannot sit neither in a squatting position, neither can, I can move my legs. It was a very, very discomfort position for me. So I remember when I was working in the hospital, I have come across one of the antenatal mother who also had the same situation like me, and she will have a gait like this, and each gate she was making faces. So I asked, what happened to you one day? Say, बहुत दर्द होता है, बैठा नहीं जाता है, नहीं जाता, like, any movement. So I asked, when do you have the pain more? She said, when I sit in the toilet. And I asked, do you have an Indian toilet or Western toilet? I said, madam, हमारे पास Indian toilet. Sacroiliitis in a squatting position is a severe type of pain. So what we need to do is we need to try to help these people how to modify their life. We can ask them to get a commode chair for some time so that he or she so that she can avoid sweating, because this was one of the movement that increased her pain level. Okay, so these are the factors which have elevating the pain. At the same time, you should be knowing what are the factors that reduces the pain. Can I ask someone, Santoshi Naga, to mute, please? So, some of the factors that reduces pain, as increases as well as what reduces the fact. Now, over the period when you are taking care of the patient, you yourself will learn that, okay, if I do this, this reduces. But ask the patient, because patient is the best person. Can you please mute in the background?
Hello,
Santoshi?
Ishita, 1 second. I'm going to remove the people who are not muting. I'm really sorry about that, because you are disturbing the people who are very well disciplined and being quiet in the class. I will remove the people who are unmuting. Now I will not ask that to mute again. I'll just simply remove. It's okay, but to have 20 people who are interested to learn. Let's be little disciplined, please. Ishita, sorry about that. Continue, please.
Oh, okay. So sometimes I get I lose the track where I was actually. So because of disturbances. Okay, well, so we were talking about the factors which reduces the pain. So you need to ask the patient himself or herself that if you had similar type of pain at home, what you used to do it. Some of the factors, this will also help us to plan our care, and also we will be able to do those interventions to reduce the pain and also to help the person. So P stands for your provoking, your precipitating, or any provocation type, any factors that increases or decreases the pain. I hope I'm clear. Next, we move to quality of pain. Now, this is a very open-ended question. Sort of. When we talk about quality, we try to quantify it, but at times it becomes difficult with it. So these are, when I talk about what is the quality of pain, these are some of the verbatim, or these are some of the descriptors which the patient himself or herself expresses it. It may be similar with some patients of the same diseases, it may not be. If I have a headache, I would say it's a throbbing type of pain, or it's a dull type of pain. It may be different for you. It may be for you a shooting type of pain also. So these are basically what the patient experiences, and he or she tells it कि मुझे दर्द होता है तो ऐसा feeling होता है. So we ask them, no, how do you feel when you have this pain? So if you ask typically a patient who has had a heart attack or a myocardial infarction, he will say that, oh my God, that was the worst pain I ever had in my life. I felt as if someone was sitting on me, and I was getting choked, all pain. जैसे लगता है किसी ने बड़ा पत्थर डाल दिया, a big stone on my chest. I'm not able to breathe. I'm having some tightness of my chest. This is what the patient will say, maybe. And if you ask a woman who have undergone a labor pain, she will say, this is the worst and horrible pain. I wish no one undergoes that. But this is some of the experiences. But it is very difficult to say which is the highest type of pain or based on quality, whether you can say it is myocardial infarction or a childbearing process. It's a controversial. We cannot have we cannot differentiate it actually to much line. But yes, as I said, pain, it is subjective. It is my pain. I'm experiencing it, so I will know what is it actually I'm feeling is all cross. So some of the verbatim which we find with the patients are, they will say it is sharp pain. Sharp, it comes like a very thin pain, sharp, and it goes. Sharp pain. It can be a dull pain. Usually a type of dull pain you will find in the internal organs, in the visceral, where you don't know, you basically can't locate that type of pain. It is a dull type of pain. You will have stabbing type of pain. Some people even say it as if someone have stabbed me on my chest. It looks like that. So these are some of the types of pain. Many people say like stabbing type of pain. Then there will be burning sensation. So typically, if you eat some spices, those who have gastric ulcers, peptic ulcers, if you eat some spicy things, you will have severe burning, epigastric burning sensation. The burning sensation even comes when you have a urinary tract infection. If you have that, when you pass your urine, you will severely feel like, something is burning type of. These are, again, some crushing, heart attack, myocardial infarction, as if someone is crushing your heart, crushing type of pain. Throbbing, typically could be a headache, pain, nauseating. Now, usually you will see this when you have a headache or a stress, you have nausea, vomiting as one of the symptoms which comes because of this nausea. When you puke out, you feel as if a little bit relaxed. A discomfort, so nauseating is also a type when patient experiences a shooting type of pain. In a trigeminal neuralgia case, where it comes, severe pain comes for a few seconds and it goes, shooting type of pain. So basically, these are the areas where these are the words that patients experiences. Twisting, very much associated with your muscle sprain or muscle strain, very much of it. Okay, so you'll have this type of quality of pain. Quality of pain again helps us to know, again locate exactly, maybe is associated with the areas or the location of pain. Is it clear to all of you about the quality of pain? Next, we move to category E, which was provoking, Q, which is the quality. Now we come to R, which is the region, as well as you can talk about some of the radiating type of pain. So, region is very much specific to it. Region, where is it paining? Okay. So we are very, this is one of the common picture which you can see. I'm not going to go into the picture. Typically, when a patient complains of pain, ask the patient, show me the area. Some people will be able to vocalize it. Some may not be able to say. Tell them, pinpoint that area. It is better if the person is able to move his limbs or legs and show. Children, very, very challenging it becomes when you talk about children. For a toddler, 3 years, 4-year kids who are already very much scared because of hospitalization, with the pain, with the injections, and if he or she is experiencing a pain, it is very difficult. So ask them, have some innovative methods of asking. Ask them through a picture, okay, or give them a teddy bear or something and tell them, see, this is your teddy. If your teddy is having a pain, where you are having a pain, show where you are having in the teddy's tummy the pain. So these are some of the ways of finding out where is the pain, the location, the origin of the pain. So, based on the location of origin, we will be identifying the underlying organ which is associated, or could be the potential cause of pain. What could be the pain of it? Why is the patient having a lumbar pain? Is it a shooting type of pain? Is the patient having difficulty in voiding? Could be anticipated with renal stone or a ureteric stone. So these are in the back end. A nurse should be having a good critical thinking. I told you, we must be asking questions. The more you ask questions, the more you are getting a clear concept. Never think, okay, okay, this is the pain, I understood. Ask why, where. Where comes is where the region is. Where is the region, location of the pain? So many of the nursing assessment sheets, you will see there is a picture of a man, both in the anterior and posterior aspect, and we mark over there exact location of the pain. This is to identify that maybe you will avoid touching that area or doing any of this touching that or movement in that area, you will be avoiding, because these areas could, or this area, and it will aggravate, right? Then comes the pain is radiating or not. Is the patient having a radiating type of pain? So typically, if you talk about an MI patient, he have a chest pain, but he or she manifests with a jaw pain, a neck pain, aggravating to the shoulder, your colicky pain, pain aggravating to your lower back over there. So these are the pain which are radiating. Is the pain confined to one area, or the pain is radiating to it? So this again helps us to have our interventions and plans and plan our nursing care accordingly. So we completed P, we completed Q, we completed R. Next is what? S. We move to S. S is severity. It is also symptoms associated. So, as we were discussing, now pain is subjective, yes, but we need to quantify it. We need to measure it, because we cannot make a general statement that today if I tell after this session all of them will become excellent in managing pain. It's a very vague. I may say that 60% of their pre-test knowledge may be improved to 80%. I'm having a scale to measure. I'm having a scale, right? So a pain has to be measured with all the verbatim, with everything region. Now comes your pain scale or the pain tools, which helps us to measure the scale or measure the pain score. So I'm not going to discuss in detail all the pain scale, because in our coming days we will have a lot of modules in this where I will be discussing, we'll be having a lot of discussion on various different scales that. So in this session today, I will be discussing only 3 types of pain scale, and these are the pretty very simple and very easily you can adopt it, easily explain to your patients. Okay, so the first is your NRS. So what is this NRS? Can anyone unmute yourself and tell me what is the full form of NRS?
Numeric rating scale.
Right, good. Numerical rating scale. The word numerical rating scale, numerical means numbers. So in your screen, you can see there is a numbers, right? So you can see there's a score of 0 to 10. So number 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. This is a numerical rating scale where you ask the patient, you have to explain what is the scale. Now, a lot of us, we nurses, we are becoming a lot of oriented. Our connection with a patient, and with COVID, it has become again a barrier. I was talking to a few of my nurses. They said, ma'am, even we want to talk to the patient, but with the PPE kit and everything, we are not able to connect with the patient. Sometimes it is a challenge. It is becoming like that. But nevertheless, your communication should and you should be able to explain what is a scale. So, numerical rating scale is a scale where you have numbers from 0 to 10. 0 means you don't have any pain. And this pain scale is further divided into three categories of mild pain, moderate pain, and severe pain. Right? So, what is mild pain? A patient is having pain, but he or she is maybe able to do most of the activities of daily living and it's not hindering him much. Okay. Moderate pain, 4, 5, 6. This is the pain scale where he or she is finding difficult to do some of the activities maybe. 7, 8, 9, 10 is the pain where the patient is not able to do any of the activities and pretty he's into pain, maybe he's rolling, maybe he's howling, he's screaming, could be any of this. So you need to explain the patient, the sir, I would like you to rate your pain score in the scale where 0 to 10 is a rating. As the score increases, your pain increases. So would you tell me how much would you rate yourself? This is a kind request of mine to all of you. Please allow the patient to rate their score. Often we make this misconception or there is a myth. There are a lot of myths. Maybe in our future coming classes, I'll discuss a lot of things. There are misconceptions of pain. When you say, उसका चेहरा तो ठीक है, उसको पेन ही नहीं है, he's talking, give 0. अरे आदमियों को पेन नहीं होता है. Men are more tolerable to pain, whereas women are weaker section in pain. No books tells us like that. It is experience. It is experience. Again and again, I'm repeating, I'm focusing in it. Please do not assume things and put the score. You're harming the patient. Do not go. Nursing is never ever on an assumption based. Okay, you should never assume things. You ask the patient, give the scale, tell him or her to rate the scale. That is a numerical rating scale. And based on that, your nursing management comes. We'll be discussing about interventions in coming slides. So this is one of the scale, which is numerical rating scale. I hope I made it clear to all of you. Next, we move to another scale. Okay. This is VAS scale. So I would like one of you to unmute and just tell me what is the full form of it.
Visual analog scale.
Visual analog scale.
Okay, but we have got visual analogy scale. We have got verified analogy scale. So guys, just for the sake of test, just don't write tick. I'm sure you must be knowing, but you're not careful. Some of you are not careful. The word analog. The moment you see the we have, it's I don't know how many of you have done that. There was a small piece of article which came with jumbling words and said if you're able to read this sentence, you are genius. And 30% people were able to. The words are all written vice versa, like is written SST, ISD instead of distress written it. So sometimes what happens, we pick up the first word and we interpret the whole sentence. Sometimes we do this even in our exams. I've seen, even I have done it. Please read carefully. This is called visual analog scale. Visual means you're able to see that. Okay, visual. Analog, very similar. You're trying to have a signal or related to, and you're going to score it. So this is basically a 10 centimeter scale. Again, it has 0 to 10 score. You have to ask the patient, see and rate it. Now, sometimes you also have a color coding. Now, in a VAS scale, where NRS is basically for the literate people who knows the number, who are able to understand, it is for those who are very cognitively able to do it. But sometimes visual analog scale, suppose a person who is illiterate, maybe you can ask them with the color codes. You can say, as the color of as the color becomes darker, like greenish to yellowish to dark red, your pain increases gradually. So this is one of the way you can explain them. With the colors you can say, or you can just say this, the color will not have any number. The person will point at the color and behind the scale will be the numbers written. So you'll know, okay, this yellow, that means it is the pain score of 5. It is it is challenging sometimes for us, like when we have a nursing fraternity, have a lot of multilingual people. We work all across the country, north, south, east, west. Our communication becomes a barrier when you don't know the language of the population you're catering to. So sometimes maybe you are working in a south and you don't know the language of it. How will you explain the pain scale? Will you just rate it by seeing smiling? So no. So you have to come across. So suppose I tell there's an illiterate Mataji and who doesn't know how to count and other things, a rating scale and all. So you can ask them, "Ye mutti band karo." There's a fist over there, and so this means no pain. As you are experiencing pain, increase your एक finger, two finger, three finger. Pain jitna बढ़ता है, as the pain increases, or you having increase, just take out one finger of yours. This is one of the way you can ask your patients to score them. So we we want our girls, our nurses, our upcoming future nurses, because you are all going to be leaders. You need to train them, because not these things are not taught in our colleges and all. You don't see much inculcated in that, but once you come to clinical practice, this are what we require. You need to understand from the patient perspective also. So we came to numerical rating scale, we came to visual analog scale, and we have the last scale, which is pretty very happy, and everybody, I think most of us love this when it comes to the face scale. So this is Wong Baker faces scale, or the Wong Baker's facial expression scale. Usually we use for children who cannot read the numbers. So we tell them, can you look at the faces and tell me where you fit, how much you're having your pain. So they are very happy with the faces. So yesterday when I was just doing a dry mock on this, I said, let me try out with my son who is 5.5 years. So I called him and I said, Baba, tell me, do you have any pain? He said, no, Mama, I don't have pain. I said, which face will you like it? So he counted into the happy, Mama, happy smiley face. So these are the smiley faces which helps us, for children. Pediatric nurses, those who are, it is quite challenging, because you need to adapt your nursing skill and come to that level to understand what he or she is able to say. So for adults, we give directions, they follow. But sometimes it becomes very challenging for your geriatric age group and pediatric age group, when they are very resistant to understand, maybe because of the cognitive factors or something. So we need to have some innovative methods. So nurses are becoming innovative. I agree with that. So you need to find out which method will be useful for me to understand which scale. Selecting the right scale will help you to rate the score, and also it will help you to plan your care accordingly. Now, if you see a pain scale, pain score sheet, you see there is a 2, there's a 6, there's a 5, there's a 2, there's 1. Inappropriate. You cannot map the score. It is heavy. What does it depict? What does it depict? First thing, what scale did I use? Did I use a apt scale to use it? Because I may use a faces Wong Baker scale for a patient, and my next duty nurse will use it for, we will use VAS. The third night duty staff comes and uses an NRS scale. It will not have consistency. When there is no consistency in the scale and you are using inappropriate scale, your score will be very different. And it will show then either you're not giving good care, or actually it is not the good care. It is that you have not identified correctly the pain score. So I want all of you guys to identify at least these 3 scales. They are the very easy scales. Even for patients who are cognitively impaired, you use the facial Wong Baker scale. Or suppose a patient is not happy with the NRS scale, he doesn't want. Okay, you just give the face scale and say, sir, I would like you to rate your pain scale based on the faces. Just tell me, how do you feel when if you're having pain? What will be your facial expression of it? Give it to the person. He or she will point it out. Repeatedly, I'm telling, please give it to the patient, give it to the patient. Let them, him or her, rate it. So this was one of the thing where we come to severity of the pain. How to assess that. Symptoms. What are the symptoms associated with pain? I have a lot of symptoms. Headache, if you have nausea, you can have your increased heart rate, blood pressure, your pulse will go higher. You may have in stress, sometimes even in anxiety, you may cough, you may have some tremors, dangling situation, dizziness or shaking of the hand. These are also some of the symptoms which is associated with pain. So it is not only the rating scale, a good nurse will also look into the face, look into the physical activity of the person. If you see a child basically who doesn't want to come to you, or you can just observe. I give more of child because I'm from a pediatric background. I remember I learned this from one of my doctors in CMC who said, before I call another next patient, the mother and the baby will be standing at the door of the OPD. I usually don't call after a patient leaves because I'll just closely observe my next child, because a good observation is required to know how he or she is reacting. The moment the child comes and sees a white coat with a stare or something, they start crying, right? That's a fear factor for them. So look into these aspects when you're taking care of a child as well as an adult. Coming, we have finished P, Q, R, S, and the last one is a T, the time factor. It is very crucial to know why it is. Now, here, T have a lot of questions. We as nurses should be asking questions to the patient to know what is happening back end, what happened, time, questions. These questions will help us to, you can map in yourself, okay, this is what happened, that is what happened. So these are the things. So first thing, when and what time did the pain start? This is talking about your onset of pain. What time it started? कितने बजे शुरू हुआ? Onset, what time it started? How long did it last? Duration. What was the duration? Was it for small? It came for a second and went, or it stayed for a long time? How long? What is the duration of it? How often does it happen? Does it come weekly? Does it come daily? Does it come hourly, monthly? Some patients say, it comes har week ko aata hai. So then we'll ask them, har week ko aata hai. So is there anything that you have been doing, anything associated that weekly you have performed any activity, or you had any food or anything particularly thing that it happened? Could be any of this. Is it gradual or sudden? Is it gradually it comes, slowly it's coming, or suddenly it came? कभी कभी होता है ना, you're doing something, suddenly your head just turn and you sit down. It's what happened? No, getting a like sort of dizziness. Sudden thing. Is it a sudden or a gradual? So what have you done when you have experienced this pain? So this is very, very important. We cannot alleviate all the, you cannot do all the measures to relieve the pain. Ask or get the help from the patient and the family members. They are the best one. So what you used to do this, if you had a pain, throbbing pain, headache like this, or you had a leg pain, what you used to do at home, because these some measures you can apply. You can also help that in the hospital and reduce the pain. Is it sounding good or not? Or all of you are sleeping in the afternoon? Can I see some thumbs up? Are you okay? Can I have a thumbs up? Are you all okay? Sleeping? I hope no. Okay, fine. Thank you. So we have few things, few more questions that. So day and night. Have you experienced any pain which comes in the night or which comes in the day? So I have varicose vein. Okay. So usually when I'm taking a lecture or continuous walking and standing for a long time, suppose, I usually will land up with a pain in the night. So these are some pain which aggravates maybe because of the daytime, nighttime. Ask them, what is that pain? Food. Some of the food habit. When I see this food habit, I remember in the story. Okay, this is a story of a lady who was in Rajasthan. So during her pregnancy, certain things, those who are mother, that certain food you used to avoid and certain food you will like to have it. There's a craving that's called paika. So this lady used to love rajma. I think all of you know the red beans, rajma. And each time she'll eat rajma, she'll land up to hospital with severe epigastric pain, hyperemesis, and all. So first time we counseled her, we said, don't eat. She said, yes, 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 I will not eat, And she had twin pregnancy. So we used to tell her, avoid these things and all fine. Okay. Throughout her 9 months, I have seen her getting admitted at least 3 times. And all the 3 times is same cause of Rajma. So she couldn't control her pica and she will have epigastric pain. Even a drop of any, you give little water, she'll pick up. I can't have it, I can't have it. So we used to remember what is the effect of Rajma which comes off this, and she'll have severe headache, pain. These are some of the things you need to understand. Patients teach you a lot of things. So some food habits can also aggravate pain. Seasonal pain. Have you heard the seasonal pain? Raynaud syndrome, where in the cold areas, this patient go because of vasoconstrictions, they'll have severe pain. So they avoid the cold area. Arthritis patients, they'll have typically pain when the cold season comes. They'll have this pain symptoms coming. So have you ever been awakened? So you need to ask, have you ever experienced some pain which is so much that you're awakened because of this in the pain? Does it lead to anything else? Does this pain leads to any other symptoms like vomiting, nausea, or any of the thing where you cannot do some of the work? Is it accompanied by any signs and symptoms? So we have discussed about the signs and symptoms which are associated. So these are typically some of the questions that you need to ask when you are asking about the characteristic of pain. So I hope it is clear about, we have learned about P, Q, R, S, and T, all the characteristics. So far we have gone definition, types of pain, causes of pain, characteristic. Now comes the important thing. I want all of you to be awake at least now. Role of a nurse. We are all here nurses. We are called to do a noble profession, and to get freedom from pain is a patient's right. If I ever ask, death is something inevitable, I always tell this. How many of you would like to die in a road traffic accident or in pain? So everyone is, ma'am, what are you asking? We don't want to die in pain. None of us, right? And we don't want our pain to go so high that you try to kill yourself. Yeah? Anything? Anybody wants to share anything? I could hear something. So pain is something we all want to get relief of. So it is a patient's right that he or she is relieved of pain. And there where the role of nurse comes. I won't say a doctor's role. It is a nurse who is there round the clock beside the patient. It is not a doctor. So in one of the international conference, one of the CEO asked, tell me, why do patients get admitted in hospital? So many people, the doctor care, this, because of better care, this thing. Wait, this person was a non-nursing, non-medico, first of all. He simply said, it is because of nursing care. Because a nurse is there 24/7 beside, where you don't get in OPD that services, or So a nurse plays a vital role in the patient's life. Now, I hope all of you know that pain is the 5th vital signs, right? So you have the temperature, pulse, respiration, blood pressure, and your vital signs. What pain was given as the 5th vital signs? We'll reflect few things in this. Okay. The most of the care, as we have, while we opened the discussion, so we said the most of the people seek medical help because of pain. So one of the common reasons for admission is pain. So, they have seen that because of pain, so patients get admitted. Pain gets its due importance and respect. So it is a focus. When you're doing a vital sign, your 5th vital, it is a due important focus. Why? Because nurse is we are trying to give a holistic care. We're not going, our care is not fragmented. We are giving as a whole. It's a bouquet. I always tell your nurses, as nurses, we give a bouquet of care. The bouquet has red roses, purple, white, it has leaves, everything. We cannot say, hey, guldasta dena, we don't say, give me a bouquet of red rose, pink rose, purple rose. No, we don't. We say give a bouquet. Bouquet is a holistic approach to the care. So pain, as we say, vital parameters do changes with your heart rate, blood pressure, and respiration. So your pain is significantly affecting your vital parameters. Okay, so that's why we have the pain given so much of focus on pain management. Some of the key points of pain management for the nurses. First and foremost thing, identify the pain. How do you identify it? Some patients verbally say, I'm having pain. Some may not be telling. There where comes. Please do not assume by just telling this patient doesn't have pain. Identify it correctly. Ask the person, sir, are you having pain? Any sort of discomfort? The word pain may not, some people will think pain matlab dard ho raha. Some type of discomfort, unpleasant feeling is a pain. Identify it. Use the correct tool to identify it and measure it. Now, once you have identified, yes, my patient is having pain, use the correct method, use the correct tool to score the pain. If your scoring is incorrect, your intervention will be incorrect. You will be not able to, you're not going to help the patient. Timely intervention. Now, what are the interventions we do? Now, this is a very common scenario I've seen in my experience, past experiences. The moment a patient or the patient attendant comes to the nurse's station and says, sister or brother, my patient is having pain. Okay, so what he or she does, takes the file. हाँ अभी तो 2 घंटे पहले तो पेन का दवाई दिया था और हाँ पेन मेडिसिन is going on. First intervention, acknowledge it. Please acknowledge it. Don't close that sentence and by saying I'm giving you pain, now you painkiller, you sleep. No. Timely intervention. Go to the patient. See where the patient is having pain, the region of pain, what type of pain is she or he having it. Ask them. Okay. Simple comfort measures, very, very important. Comfort measure. We forget. We have become so much of, computer savvy, gadget, and everything. We forget the basics where we have come. I still remember when I closed my eyes. I remember my teacher in CM Civilor who taught me first year comfort measures. We used to have a logbook we signed. Get pillows, 2-3 pillows for comfort measures. Keeping one under the neck, trochanter roll, side lying position, knee flex to the abdomen. These are some of the basic things. Tell me how many of you, when you have a pain, abdomen pain or something, you take a pillow and you try to cuddle that or you try to lie in one side? If you and me can do that, why not we do it for our patients? So timely intervention, some comfort measure, some soothing, some music therapy, some of the cognitive behaviors of how you can change. In oncology, I have seen a lot of patients dying, very young age, child, a young woman, 24 years old, just married, having 1-year-old child and, diagnosed with ALL, AML. So when I remember music therapy, I always remember that girl. Her face comes in my mind, just in front of me. Till the last moment, when we know she's dying, she's having pain, she used to, her mother used to play that Gayatri mantra just near the pillow. Some people love some soothing music that reduces. Sometimes you don't need to do it. You just talk to the patient. Ask something which he or she likes. If someone likes to talk about cricket, maybe you may not like cricket, you don't know. And he's, Arey, yeah, Dhoni, even I like Dhoni, oh, lovely, yes, he's my favorite, Or some talk about some hero. Or you like Amitabh Bachchan, even I like. And engage in some talk. This gives, psychologically, he or she will be out of that pain. Because sometimes pain, something is in our brain. That they're there. Try to distract. Some simple intervention, some hot and cold application will be able to soothing the patients. So timely intervention. Don't worry about when hum baad mein karenge. Now another coming to medication. Now medication is our favorite thing. We always give medication. We should know what is the onset of medicine. If I'm giving IV morphine or IV fentanyl, what is my onset of the drug? I cannot say I've given medicine, I'll come after 15-20 minutes. No, I've given an IV. I have to stand there. I have to see the onset. Yes, immediately. The action starts within 1 or 2 minutes. I hope all of you know the pharmacology there. Whenever you give any drug, there is an onset, there is a peak, and there's a duration. Duration is when the threshold finishes, the action of it. So we need to focus on onset of the medication. You have given sublingual, intranasal 12 to 15 minutes. Sublingually, you have given any medicine, you have to wait how long? Just a minute or two. You have to stand there. You cannot go and say, I'm coming back after 15 minutes to assess. Yes, if it is some oral medicine, right, agree. Oral medicine, you have given something, yes, the onset will take 30 minutes. You need to come back and reassess. Our next is reassess. We have done excellent intervention, we have done it, but we forget to reassess. What happened to my patient? Is my patient comfortable? Has his pain score reduced? Is he able to move? Is he able to do some activity? Timely reassessment. Now, many of you will have a reassessment of pain scale, a pain score. Many of the NABH hospitals, it is one of the criteria. I remember doing two of my hospitals, accreditation of NABH. This is one of the area where most of us will get NC, that is non-compliance to it. We have not done reassessment. We failed to do some reassessment, timely reassessment. I'll give you an example which happened for me in my NABH assessment. So we teach a lot of bombard with a lot of trainings and teachings that assessment karna, reassessment. So my nurse said, madam, karenge. So on the assessment day, you see there are a lot of 15 minutes, 30 minutes, lot of assessment, reassessment after giving pain scale. So these assessors are very clever. What they do, they pull your medication chart and they see and they match what time was exactly the medicine given. So what they do, they see, okay, the medicine was given an hour back, and they started, doing the assessment maybe after an hour. What is the onset of the medication? They ask, what is that? What is Dynapar? When does this action start? So you should be very careful when you are giving any injection, any oral medication. You should be knowing what is the onset of the medicine and reassess after giving any interventions, whether it's medical, in terms of medicine or in terms of any therapy. You need to come and reassess. And last but not the least is timely documentation. So in my career in Fortis, I learned something from one of my ZD, that is zonal director. He called me and said, Ishita, I would like you to take one takeaway message in Fortis. I said, yes, sir, what is it? He said, whatever you say, you document, and whatever you document, you must say. This has a very, very deep meaning. We sometimes only document, but we fail to assess and reassess. Now, any documentation done without assessment is not correct. It is not right. You're cheating. It's a forgery. If you have not done, but you have assessed, you have not assessed and you have just documented, this is wrong, right? So if you have reassessed correctly, you also need to document. Sometimes you say, ma'am, when I used to have counseling with some of the nurses as to why you have not given this medicine or you have not done. Ma'am, I have done it, but I forgot to document. What does it mean? It means you have done it, but there is no proof. You need to document. Both assessing and documenting, reassessing is very important for this. I hope all of you will remember this. I hope you all know what is the 4 Ps, okay? That is the purposive rounding. This is called Purposive rounding. We take a lot of patients around, right? We go n number of times in your 6 hours or 12 hours of duty, n number. But we tell you to do an hourly rounding, which is called as purposive 4P rounding. What is this purpose? You are going to the patient with a purpose. What is the purpose? The first P is pain. Next is potty, that is for the elimination. Do you need a bedpan? Do you need to go to the washroom? Possession. Possessions are any of the belongings the patient wants. Is the nurse call bell near to the patient bedside? Is the glasses there? Is the water there kept? Is the TV remote next to the patient? Is the AC remote near to the patient? Possessions. Position. A comfortable position. Are you comfortable in this position? Should I lower down the head? So these are what a good nurse, we need to train, we need to coach ourselves as well as mentor our juniors who are going to come into this profession and who are there already on board with us. So these are the 4Ps. Now this is just a thought. I'm not going into these again, a lot of stories. So these are some of the non-pharmacological interventions that we have, both for a pediatric and for the child. For a child, you would see those who are working in a neonates, you try to make a nest for the baby, right? We make with bed sheets or the rolls, towels, we make a nest, a U shape, to give a comfortable position so the baby thinks that I'm still in the mother's womb. Some of the rocking, some we try to rub the baby, cuddle the baby, give some pacifiers. These are some of the measures to reduce the pain, elevate the pain. Coming to the adults, we have a lot of other things. We have a lot of distractive items, like we discuss about the therapies like music therapy, some videos, some apps, or something like that, sort of just to distract the person. Some relaxation, breathing, relaxation. You need to meditate. Now, many of the hospitals have started yoga. I know yoga therapy, meditation therapy, just to relax yourself, just to make your mind free of anything that is happening all around. Focusing only on yourself. Music therapy, guided imagery. This is one of the lovely thing I love. I usually do with my son when he's in online classes, and we get a 5 minutes class and he gets very bored. Mama, I don't want to read and study. So I tell him, okay, close your eyes and now let's do something game. Imagine you're going, in a flight, and the flight, he loves aeroplanes. So I have to give some examples which basically he loves. So you're going to a flight, it's taking off, the wheels you can see slowly you're going, and then you see the clouds over there, then slowly the AC, you feel the cool breeze, something like that, just to keep a person again distracted. So these are guided imagery, some therapeutic, language, some conversations of it. So these are basic, some interventions apart from non-pharmacology. Yes, we will do pharmacology, but these are interventions which needs to be included in our care plan, in our interventions. As a nurse, we need to. And I think in ancient time, we were doing only these rather than calling the doctors and giving medicines. These were you go to some of the therapies like massage therapies, they actually work with these. So some of the missed care that is in care, common things that we miss in a day-to-day in management of pain is failure to use inappropriate, or we failed to identify the appropriate pain scale, and we pick up an irrelevant scale to it. So judiciously, before you select the scale, look into the background and take up the scale which is necessary. Failure to educate the patient on the use of pain scale. Now, those who are from a JCI background, you must be, in 2018, they have said that one of the elements of performance, I think 7, it says that only pain scale, measuring the pain score by pain scale is not enough. Now, they want to know what is the effect of your pain management. This is something very important, Please note it down when that you need your pain, your goal should not be pain is minimized. This is a very vague thing. Your goal should be SMART. What is SMART? Specific. S. It should be very specific. Post-operative patient, day 1. My pain, my goal is he or she is able to breathe normally without pain. Goal, very specific. It should be measurable. I should be able to measure it. I cannot say just vaguely pain is reduced. Measure it. How? I want the pain scale score, which is 6. I would like the pain score to increase to 5 or decrease to 5 or 4. Very specific. Specific, measurable, smart, achievable or attainable. I will not set any goal for my patient which is beyond achievable. I cannot say next day my patient is able to walk completely after the surgery. No, 2-3 chakkar lagayega in the ward. This is not acceptable, not achievable. So say I would love my patient to just first day 1 get down or sit up position or just get down from the bed. Day 2, I would like him to walk 2 steps out of the bed. Day 3, I would like him to walk out of the room. So these are very goal specific, your objective should be. So specific, measurable, attainable or achievable, SMART are realistic goal. Set realistic goal, not an unrealistic goal. You need to be very careful. Today, as I told you, I don't want that after the end of the class, everyone will become expert. 10 out of 10. No, this may not be because each individual is different. Each one, when I'm teaching, each one is comprehending their mind separately, right? So have something which is within reachable. So I may say maybe 60 to 80 or 90, something realistic. And it should be time bound. It should be time bound. So specific, measurable, attainable, realistic, and it should be very good time bound. So now when I talk about, I was talking about JCI, that they say that what is the effect of your pain management? They want to see it on the patient. Is it hampering or is it improving their activity of daily living? So I give a pain management, any medicine, or I have done a therapy basically on it. And finally, I need to measure it, what happened at the end. Suppose a patient who was rolling with pain, is he after giving pain medication? Is his pain control? Is he able to get down from the bed? Or, he is able to sit up on the bed or he's able to do some of his activities. So is it affecting your activities of daily living or not? So this is something which is very realistic and which is, we can see what is happening. It is very obvious, okay? Involve the patient and family. Please involve your patient and family in your education. It is very important that we need to involve them because after all, it is they who are going to take care. You are going to be only in the hospital for a few hours, few days. Later on, the relative only have to take care. So help them how to manage pain at home. Ask relevant questions and look at the pain site. Please tell them that you need to look at the pain side, relevant. Ask, you also need to see, just not say, acha pain ho raha hai patient ko. Go see, ask the patient, do your assessment, and then you need to inform your physician. Failure to consider non-pharmacological measures. Now, this is very important. We often forget what is the measures of it, non-pharmacological measures need to involve, and a lot of non-pharmacology therapies have come. In coming days, we'll have one of the modules where we will have pharmacological and non-pharmacological measures to relieve pain. So we will be discussing in that upcoming classes also. And failure to do timely assessment and reassessment after intervention. So we need to be very, very careful when you're doing that. After intervention, please do reassessment and also document it. I hope without failing, you will be able to do this. So something pain management, that is post-operative pain. Now, when you're working in a special ward, like post-operative surgical wards, and you have huge OT list today to be done, and you are busy. So this is one of the tool you can use. This is called Functional Activity Scale, that is FAS, F-A-S. Functional Activity Scale. You can do a triaging on your patients. Very simple thing. If you are given any intervention, see whether any no limitations, mild limitation, and any significant limitation. So what is it? I have given medicine. Is the patient able to do some of the activities, or he is able pretty fine? He is having pain, but he is doing most of his activity. That means no limitation. Though pain is there, but the patient is having no limitation. Mild limitation. patient is having moderate to severe pain, he may not be able to do every activity, but yes, some activity he is able to perform by himself, right? And the third one is the worst pain patient is experiencing after giving pain medication also, and there is patient is unable to do any of the activities, so completing. So this is basically again significant limitations of pain. So this is something new. I would like all of you to take this. Maybe you can use it in your own hospitals over there, a tool where you can able to identify how effective is your pain management. Based on that, you can accelerate it, to your higher your team, pain management team, basically on what activity or what are the other interventions you need to do to reduce the pain. So, a lot of stories we have shared, and one of the story I would end up. I would love all of you to remember this session as a story day. Okay, because I told you I love stories and I love sharing stories also. So a lot of stories I have shared. One of the last story that I would love to share with you is this. One of my patient who underwent hysterectomy, okay, some 2 years back, and this patient was on a PCA, that is patient controlled analgesia, which is analgesic, your epidural infusions. After 48 to 72 hours, the epidural was removed, and we thought, okay, fine, the patient is able to walk and move everything. Soon the epidural was moved off. This patient, after half an hour, started complaining of some burning sensation. She's lying in the sofa and said, I'm having a burning sensation somewhere in my buttocks. And I, buttocks? Why in the buttocks he is having a pain when the surgery is in the abdomen? We said, ma'am, are you sure? Huh? I'm having a pain in my abdomen, severe pain. And then suddenly we said, okay, let us see what is happening. You'll get a shock to know what happened. We turned. I was there. I said, let my nurses, my gynecology nurse, let's turn. We turned and we saw around 6 by 7 millimeter cautery burn at both the buttocks. We were shocked. We didn't know what to tell her. And she said, I'm having, and it was not the surgery pain, surgical site pain, it was a cautery burn pain that she's having. So remember, when a patient complains about any pain, please do not ignore it. Please try to help and see. Judiciously and critically, a nurse should understand thing. When a patient is coming from a surgery, if there is no contraindication, turn the patient and see any cautery burns, any mark, even sometimes the staplers. Patient may be lying on some of the hooks or stapler, the scissors, because of which the patient have got a pressure sore. Need to check many of these aspects. One of the post-operative challenges, I think many of you would be agreeing with me, is patient refusing for ambulation and the physiotherapist coming and writing in the chart, patient refused to ambulate. Have anyone thought about why is this happening? And we know what is the complications of patient if patients are not ambulated. DVT, patient will get anything, stroke, MI can be, CVA can be because of this. So in this time, nurses play a vital role. You need to know what time the physiotherapist is coming. Is the right medicine given before? Is the medicine being given? What is the onset of the medicine? Then only we can educate the patient. I agree sometimes patients will be lazy. They'll say, I don't want to do. Encourage the patient. Tell the physiotherapist that this is the time I have given the medicine. You will wait for the action. Patient will, just don't say, I have given medicine and go. Educate the patient, be with the patient, help the patient to come out of pain. So there are a lot of stories that I think in this hour, we have 2 hours, I think I have shared. And just to summarize, we have got a snapshot of pain, types of pain, causes of pain, the characteristic of pain, the intervention, and some of the areas where we as nurses need to be more focusing. These are some of the areas where we miss out. We need to focus on those areas and help a patient to live a life with pain-free. And with this, I just end up my session of today's snapshot on pain management. I would request Tangam ma'am to just come and take over and she will be helping you and guiding you on how to get your e-certificate and how to do your post-test. Thank you so much, everyone, for your valuable time. Hope to see you soon. Bye.
Thank you, ma'am.
Ishita, just move the slide, please, to the next
Yes,
slide.
ma'am.
Yeah.
Yes, ma'am. Sure.
Your slide, you didn't, I think you stopped sharing the slide. Can you put the last slide where I have
Oh,
written down how to get the
okay,
certificate?
ma'am. Sure. Just a second, ma'am. Just give me a time.
Okay, meanwhile, she's getting the slide up. So let me ask all of you that how did you like the session? You can give a number on your chat box on a scale of 1 to 5. Just type how much did you like this class from Ishita. Just put a number. 5, you liked it very much. 1, I was sleeping in the class. Okay. All right. So looks like nobody was sleeping in the class. Very good, very good, all of you. Ishita, just put it back, please. Thank you very much for your encouraging feedback. Ishita, I don't have the details. Where's your?
1 second.
Go to
Yes,
the
ma'am.
last. Yeah. Okay. Just leave it like that. All right, ladies and gentlemen. Now I'm going to tell you how to get your certificate. It's not